An overview of today's talk includes we will generally describe what is the field of cardio-oncology. It is, say, probably one of the hotter fields right now within cardiology. How to develop a cardio-oncology practice. What is strain imaging? This plays a big role in a cardio-oncology practice. The American Society of Echocardiography consensus statement, and a new standardization task force initiative, and then finally conclude with a few interesting cases. Cardio-oncology is really a bridging field, and it's an intersection between cardiology and oncology. It's a growing field that is growing alongside cancer survivorship. With increasing cancer survivorship, we are seeing that cardiotoxicity from anti-cancer therapies can be the primary determinant of quality of life and mortality in these patients. As some of you may know, a patient with early stage breast cancer is now more likely to die of heart disease and complications from cardiotoxicity than of breast cancer. Some of the goals of a cardio-oncology practice include, 1, to provide a seamless care between cardiology and oncology services for all cancer patients with cardiovascular issues, perhaps predating treatment or while on treatment. Number 2, to improve patient outcomes by developing structured management algorithms for cardiotoxicities to prevent or minimize cessation of chemotherapy. And number 3, to provide state-of-the-art advanced left ventricular assessment with emerging imaging technologies, and provide this to all oncology patients at risk for developing adverse cardiac outcomes. And this is really where imaging is advancing and where Epsilon has a niche as well. So how do we develop cardio-oncology, a practice in cardio-oncology? There's really 2 different models. One model is where the cardio-oncology practice is located in an oncology clinic. The pros of this being that there's definitely more face-to-face interaction between the cardiologist and the oncologist. It is much more convenient for cancer patients if all of their doctors are located together. The staff has a familiarity with oncology disease and what to anticipate in terms of perhaps side effects from chemotherapy treatment. The cons to a practice within this model is that there is less access to cardiology testing, perhaps. It's not as readable to obtain an echocardiogram or an electrocardiogram or stress test or whatever other testing cardiac testing the patient may need. However, this con could certainly be overcome if there is space within an oncology practice for to house cardiac imaging, such as even a single echo machine. This may be something to think about if this model is pursued. The model that we have here at Northwestern is more of everyone is in their own comfort zone. The cardiologist, myself, practices within a cardiology clinic, and the oncology or cancer patients come to that clinic. And so the pros to that is that there's definitely real-time access to echocardiograms, diagnostic testing. If I need any additional testing done during clinic, I can just reach out to sonographer and say, can you grab a couple extra pictures, or can we just put a probe on the patient? Let's take a look, let's review, see if the pericardial effusion is bigger in size. There's more real-time access to both echoes, EKGs, and stress testing. The pros also include that our staff are more familiar with cardiac conditions. However, one of the bigger cons, and it really is something that requires work to overcome, is that the physician-to-physician interaction, particularly at larger institutions or large hospitals, there needs to be more of a concerted effort to reach out to the oncologists, the nurse practitioners, the advanced nurse practitioners, to educate them about the program, to bring visibility to the practice, and to bring not only visibility to the practice, but so that we're all on board, that we have sort of the same goals for our patients, and that this is available to them. We also, as I have also found, that since we do practice this model here at Northwestern, that there needs to be much more flexibility in patient scheduling. Oftentimes these patients need to be seen quickly, or the time frame is shorter, and so there needs to be much more flexibility if they're coming for an oncology visit or for chemotherapy or for radiation treatment. We can also schedule the cardiac visit on the same day. So there's a lot more flexibility needed within one's schedule to see patients. Some of the referral reasons to a cardio-oncology practice that we've had here kind of can be divided into three different groups: the pre-anti-cancer therapy, during and ongoing cancer therapy, and then in the post-treatment realm, or during remission. So for the pre-treatment evaluation, the most obvious are those who have known cardiovascular disease, have known history of CAD-MI or heart failure, to be seen before treatment, make decisions about treatment as to whether treatment can be safely given to patients, with especially those treatments with known cardiotoxicities. The biggest portion of patients we see are those who are undergoing anti-cancer therapy, those who develop LV dysfunction, whether it's symptomatic or asymptomatic, while on treatment, those who have chest pain, if there's a question about ischemia or vasospasm causing the chest pain. We often see patients for hypertension management, pericardial effusion or pericardial disease assessment, effusion or constriction, and then arrhythmias, assessing EKGs for QT prolongation, pre-clinical trial or while on clinical trials. And then, of course, in the anti-cancer therapy post realm, patients need to be reminded of their long-term cardiovascular risks after having undergone certain types of treatment that can cause cardiotoxicities. Let's quickly review myocardial fiber orientation now, and how that is important to thinking about the principal vectors of strain. The endocardial fibers in the heart muscle are directed on a longitudinal fashion. Circumferential fibers, which predominate the mid-wall, about 1/3 of the heart. And so strain, if you think of it in its most simplistic sense, is actually the lengthening, shortening, or thickening of these fibers in three principal directions, that being longitudinal, or an up and down motion; circumferential, which is more of a twisting motion; and radial, which is the thickening of the heart muscle. However, strain is not what is the primary criteria used at this time to define cardiotoxicity. It is ejection fraction. So before we talk about what's abnormal, we need to define what is normal. And normal, based on new data from 6 different databases, normal ejection fraction by the Simpson's biplane method is an average of 63 plus minus 5%, ranging between 53 to 73%. And this definition of an ejection fraction at the lower range of 53% being the norm is an update to the American Society of Echo guidelines. So now that we understand what is normal, what is abnormal, cardiotoxicity, another fancy term for that, is cancer therapeutic related cardiac dysfunction, and this is defined as a decrease in ejection fraction of greater than 10% to a value less than 53%. This can be subcategorized into reversible, partially reversible, and irreversible. Reversible is when the ejection fraction is within 5% of the baseline. Partially reversible is if it then improves by greater than 10% from its nadir, but still remains less than 5% below baseline. And irreversible is that if the improvement is less than 10 percentage points from the nadir and remains greater than 5% below baseline. Echo is our workhorse in terms of monitoring and surveillance for cardiotoxicity in patients. We know that echo does have a lower sensitivity to detect small changes in ejection fraction, and that subtle changes may not be detected by the ejection fraction. 2D echo is reliable in detecting differences, closer to 10%. The problem is that this magnitude of 10% is actually the same magnitude of change that we use when we define cancer therapeutic related cardiac dysfunction. Some of the more specific issues that we have with echo in our patient population, and specifically the breast cancer patient population, is that the image quality and precise endocardial border definition may be problematic. This can be seen in breast cancer patients who are post-mastectomy. There's scar tissue, radiation. Oftentimes patients have expanders or breast implants that prohibit good image quality and an inability to visualize the true LV apex. Other things that affect ejection fraction include loading conditions. If a patient is having a lot of nausea, vomiting, are dehydrated when they come to get their echocardiogram done, their ejection fraction may be a few percentage points higher. And this, if it's the baseline ejection fraction, may then affect the subsequent surveillance ejection fractions. What is the difference between wall motion versus deformation? Wall motion cannot distinguish between active and passive motion. What is meant by that is that if there is a part of the wall that is infarcted and is moving because it is being tethered by an adjacent portion of the heart, wall motion cannot distinguish whether that part of the heart is actively moving or passively moving from the tethering of an adjacent part of the heart. However, deformation can distinguish between active and passive motions. We're actually looking at the motion of the myocardial fibers themselves. And so deformation is often described as what the eye cannot see. Myocardial deformation is strain. These words are used interchangeably. Strain is the total deformation during the cardiac cycle relative to the initial length at the onset of the cardiac cycle. It is expressed as a dimensionless and negative percentage for longitudinal and circumferential strain. So this is a cartoon image showing what is strain imaging. And the cartoon is a myocardial fiber. That's what we're depicting, and it's up and down or longitudinal motion. At the top, we see that as the muscle fiber shortens and lengthens, we have a negative strain curve. Now, the curve is positive for radial or thickening. and also negative for circumferential strain. So strain is the percentage of change in the length of the myocardium during relaxation and contraction. It can be thought of as change in length over the original length at diastole. So if we take the myocardial length at end diastole and subtract the myocardial length at end systole, that change divided by the initial length at diastole gives us our strain percentage. Deformation imaging can be assessed either through tissue Doppler or speckle tracking. Tissue Doppler imaging is the first form of strain imaging, and it measured velocity of the myocardial tissue with a wall filter. There's a high-pass filter that images blood velocities and a low-pass filter that images tissue velocities and eliminates the high velocities. However, the drawback to tissue Doppler imaging is that it is single dimension. It is a single dimension. It is in the single dimension, and that the alignment of the ultrasound beam with the wall is very important. As this cartoon depicts, the measured velocity, which is the yellow arrow, can be underestimated if the ultrasound beam is not aligned with the wall. And so in order to optimize tissue Doppler, sonographer must narrow the sector, and a single wall acquisition will also decrease this angle of incidence and improve the tissue Doppler assessment. We are moving towards predominantly using speckle tracking to assess strain imaging. Speckle tracking is essentially looking at the fingerprint of your heart muscle. So on echo, there are natural acoustic markers or speckles that can be seen throughout the myocardium. And using standard echo B mode imaging, this speckled pattern, which is the backscatter generated by a reflected ultrasound beam, is then followed frame by frame, and we use a block matching to follow the speckles frame by frame. The displacement of the speckles is then considered to follow this myocardial fiber movement, and represents, and this change in speckle motion then represents your deformation or your strain. And here is a cartoon depiction of the speckles within the myocardium at systole and then at end diastole. The software finds the speckles, the similar speckles frame by frame, and calculates the change in length over the initial length at end diastole to give us our strain percentage. Advantages of speckle tracking over tissue Doppler imaging are that speckle tracking is in both the second and third dimensions. And software is being developed to look at it in the fourth dimension. It is angle independent. It can provide longitudinal, circumferential, and radial parameters. It can provide epicardial, mid-wall, and endocardial evaluation as well. So the software algorithm follows a defined region of speckles frame by frame, extracts the displacement, extracts the velocity, the strain, and the strain rate. Frame rates that are used to calculate speckle tracking are generally between 40 to 90 frames per second. If a strain rate falls below that number, you may encounter an undersampling error in which there is a loss of speckles in successive frames. And when a speckle moves out of a plane and that plane is not sampled and that speckle can no longer be found, strain cannot be calculated. Variability, tissue Doppler derived strain has an observer variability between 10 to 15%. speckle tracking derived 2D strain, which is the gold standard for strain at this point, is an inter-observer variability between 3.3 to 3.5 to 5%, and an inter-observer variability between 7 to 12%. We've already mentioned many of these advantages and limitations between speckle tracking. I wanted to highlight that in terms of limitations, the high image quality is also needed for speckle tracking, and that if a study is technically limited, if it's foreshortened, if there's poor endocardial deformation, you won't be able to obtain strains. This is also very important when deciding whether to report a strain number. If the image quality is poor and the strain if the strain curves do not appear to be accurately tracking, then perhaps the strain then shouldn't be reported. There's also differences between vendors in terms of the different vendors' software, and that is where an independent or vendor-neutral software can really be useful. I'm just going to quickly go through some of the steps for obtaining strain by Epsilon. When you open up the Epsilon, manager here, there's a trace wall button. Essentially, then you trace out the endocardium. It will give you a region of interest, so that would be step 1. The region of interest of the myocardium is then color-coded. An Epsilon, the end-diastolic strain is blue, and so the more negative strain is blue, and the positive strain is in the red hues. You can also select the wall detail button, and that will then provide quantitative information. So then we look at so step 2 is to obtain the qualitative information. Step 3 would be to review the strain curves, make sure the strain curves align. There's no particular strain curve that you may want to throw out. The strain is segmented into each of 3 frames, 4-chamber, 2-chamber, and 3-chamber, into 6 segments, 6 color-coded segments, and the end systolic strain value for each of those segments is superimposed onto the segments. As you see here, the segment regions are encoded in colors that correspond to their strain curves, as you can see on the bottom left-hand side of the screen, and on the top left-hand side of the screen with the regional strain curves. So it's important to review the strain curves, and here's sort of a moving depiction of that. And you can review the strain curves in this view as well with the 3 apical views that are needed to calculate global longitudinal strain. The step 4 would be to review the quantitative information. That we can obtain quite a bit of quantitative information beyond ejection fraction, including volume assessments, hemodynamic information. And so that's step 4. And then finally, we can review the bullseye. So the bullseye represents all segments and all 3 apical views. You can see on this particular bullseye that the basal and infralateral segment is hashed out, and so that strain curve may not have felt to be tracking well and was thrown out and was not included in the overall calculation. And so our global longitudinal strain for this patient is negative 15.7%, can be divided again by segment. The LV global function plot is also very useful in following serial exams and trending the strain value, which we will discuss in upcoming cases. This is just an example of radial and circumferential strain. Radial strain, again, is a positive value, and circumferential strain is defined as a negative value. The American Society of Echocardiography established a consensus statement. It was an expert consensus statement, not a guideline, for adult patients during and after cancer therapy. And in this document, there is a detailed description of what a cardio-oncology echo protocol should include. And I've included some of that information here. In order to obtain a global longitudinal strain, 3 apical views are needed, acquired in 3 cardiac cycles. The frame rates between 40 to 90 frames per second. The aortic VTI is sometimes used to define systole and diastole. Otherwise, the electrocardiogram can be used. The strain imaging quality, the strain imaging analysis, some of the pitfalls, and then also, if possible, to report the timing of the echocardiogram with respect to the actual date of infusion of the chemotherapy, include the vitals. If available, to report a 3D ejection fraction. And in the absence of global longitudinal strain, some other measures for longitudinal motion with tissue Doppler include a medial lateral S prime and a MAPC, which mitral annular plane systolic excursion. The document also contains normal GLS values between different vendors by age and by gender. General normal number to keep in one's head is for a global longitudinal strain is negative 21%. Epsilon GLS values, the relative differences between epsilon imaging calculated from different vendor data are included here on this slide based on abstract submitted to ACC. And you can see the relative differences are between 1.2 to 1.8%. In the American Society of Echocardiography expert consensus statement has also described CTR-CD in terms of 2 large categories in terms of type 1 agents versus type 2 agents. Type 1 agents are your anthracycline agents, including doxorubicin, epirubicin, some of the Taxols, cyclophosphamide, ifosfamide. Type 1 agents tend generally to be irreversible toxicity if not detected quickly, and also are dose dependent and may have long-term consequences that need to be monitored. Type 2 agents are your Herceptin, your trastuzumab, lapitinib, sunitinib, bevacizumab, some of your smaller molecule inhibitors. These agents, although not 100%, generally tend to be reversible. There are some instances where the improvement in EF is much slower if not detected quickly. But they do tend to be irreversible, not dose dependent. And in terms of the long-term effects, we're still monitoring. However, the long-term effects may be less than the type 1 agents. Integrated approach is outlined in the document. So again, if you have a, for example, patient with breast cancer who comes to you and has received ACT, 4 cycles of ACT, that includes an anthracycline, adriamycin. This patient has then the potential to have type 1 cardiotoxicity. Baseline ejection fraction is always obtained before determining if anthracycline can be safely given. ASC recommends that GLS as well as a baseline troponin may be added, and that if the EF is lower than 53% or that the global longitudinal strain value is at the lower limits of normal if the troponin is positive, then to obtain a cardiology consult. What is forgotten is the post-chemotherapy echo and reassessment of ejection fraction and strain, and then the reassessment at the 6-month point after treatment. This may be because the patient is no longer undergoing chemotherapy and is not necessary in terms of management. However, this is a very important echo to reassess for cardiotoxicity and to reassess for early changes in cardiac muscle at the post-echo and at the 6-month post-echo. We have learned that patients who are initiated on treatment as soon as changes are detected are more likely to have recovery of heart function than those who we don't know what's happening. In terms of the initiation of trastuzumab, Herceptin, and now pertuzumab, which is another HER2 agent that is being given alongside trastuzumab, and many patients with breast cancer are getting both together. Again, a baseline ejection fraction, global longitudinal strain, and troponin are needed at baseline. So some of these criteria are the same in terms of whether to trigger the cardiology consult. The additional imaging is needed, however, with patients on this treatment. Oftentimes the treatment is given for up to a year, and so baseline and then an echo every 3 months. So a patient may get up to 5 echoes within a year to assess for changes. And although the changes are generally irreversible, they are generally reversible with these agents. This is when because if a change is detected in ejection fraction, treatment is withheld for maybe a cycle or two until the ejection fraction improves. Patients are then started on heart failure treatment. So without the close monitoring for a year, a patient may develop even lower ejection fractions or a more serious heart failure condition. And so this close or tight monitoring of patients is recommended by the FDA because it really affects the degree of cardiotoxicity and the management of the patients from both the oncology side, whether or not treatment needs to be withheld, and from the cardiology side, whether or not heart failure treatment needs to be initiated. Oftentimes patients will come to us after anthracycline regimen and then initiation of pertuzumab or trastuzumab. The recommendations are similar in terms of a baseline and what triggers cardiology evaluation, and following the patient for every 3 months at the end of completion of treatment and at 6-month point for those who have received this regimen. So what is the definition of an abnormal global longitudinal strain? The actual number is perhaps not as important as the relative change from baseline. And so we currently define cancer therapeutic cardiac dysfunction as a drop in 10 percentage points to an EF less than 53%. However, we are also following GLS now, and that if there is a greater than 15% change from baseline GLS, that may indicate subclinical dysfunction. And this is a group of patients who do not have the a greater than 10% change in ejection fraction. So let me say that again. So if you have a greater than 10% change in ejection fraction, yes, we have a clearly defined patient with cardiotoxicity. Then we have a realm of patients who are getting smaller changes in ejection fraction. Say the patient comes to you with an 8% change. If you look at the trend in the global longitudinal strain, and if there's a drop of greater than 15%, that may indicate that this patient is at high risk for developing CTRCD and is someone that you need to be monitoring more closely. There's a initiative to start a standardization task force. So we discussed that there is intervendor differences in strain assessment. This document came out this past year in which an attempt was made to come up with common definitions for language in spectral tracking. The task force has also they recently published a 2D spectral tracking assessment to standardize efforts based on synthetic ultrasound data. This is another publication that came out by this task force. It's in the European Heart Journal just this past August. Essentially, the methods of that study were, this was a first step towards Q&A of all commercially available tracking solutions based on computer-generated ultrasound images, and the accuracy of the products were acceptable within relative errors below 10% with intervendor reproducibility within 5%. And so this was published in the European Heart Journal of Cardiovascular Imaging, August 18, 2015. First author is Dr. De Hooge. And so the task force is out there and is attempting to standardize strain imaging. I think we have to go through some cases now. I have 5 cases to present. The first case is that of a 67-year-old man. He has a past medical history significant for hypertension, moderate aortic stenosis. He has a higher risk form of acute myeloid leukemia and is enrolled in a clinical trial. In this clinical trial, however, he ended up in the arm that received the standard of care treatment, which 7+3, and that includes an anthracycline regimen. Again, the anthracycline is a type 1 agent. So here we have this patient's echo at baseline, which is on the left-hand side of the screen, and the echo post-treatment, post the 7+3 treatment. And you can see that there has been not only a change here in strain in the post-treatment echo, but also significant change in the LV cavity size and the LV ejection fraction. And so this was these are the bullseye for this patient at baseline and at follow-up. And the LV global longitudinal function plot showing the decrease in EF and strain. The percentage and the percentage changes. Percentage change in the ejection fraction, there was 22%. This patient group was looked at our institution because this is an oncology clinical trial in which we pulled out the echoes in this subset of patients. The clinical arm that employs the anthracycline is the 7+3, and then the arm that's being looked at to see if it has equal efficacy is the cytarabine, clofarabine, the clofarabine arm, and that does not have an anthracycline in it, and so it was useful as a placebo arm for comparison. When comparing these two arms, so this is just exposure to a short-term anthracycline regimen in leukemia patients, we do see a change in EF from 53% at baseline to 40.7% post-treatment, and there was no change in the clofarabine arms, 56% to 57.8% post-treatment. What's very interesting here is if you look just at the 4-chamber longitudinal strain alone, that was very significant. So there was a significant change in just the 4-chamber longitudinal strain. And so one may hypothesize that perhaps in the future, we may be able to simplify strain even further. The second case is that of a 55-year-old woman. She has hypertension. She has left-sided breast cancer. She's undergone ACT, which includes an anthracycline, type 1 cardiotoxic agent, as well as Herceptin, and she's now on her 1 year of maintenance Herceptin, which is also trastuzumab. This is her baseline echo, and her baseline global longitudinal strain is normal at -21%. This patient was given contrast to optimize the endocardial border definition and to get an accurate ejection fraction assessment. So the question is that can we do strain on patients who have received contrast, and this is also an area of interest and of development, but we were able to upstrain the strain in our patient, and here are the strain curves and her bullseye. And this is the same patient being analyzed with epsilon. You can see here that we're able to obtain the ejection fraction and the displacement. Her strain number, or by epsilon at baseline, was -22%. This is very similar to the other vendors' strain number, which was -21%. So then, because this patient is on Herceptin, she received a surveillance echo at 3 months. And I mean, by all visual assessment, the ejection fraction still appears normal. The patient is asymptomatic, and there's no reason that this would, raise alarm. However, when doing the global longitudinal strain on this patient, one notes that the strain number has actually now decreased from that -21 to 22% to -16%. So that is a greater than 15% change in strain, which we said indicates subclinical LV dysfunction, and the ejection fraction number did not drop to greater than 10%. There are several studies in the literature that have looked at trending the strain number with our surveillance echo, and how that can be a prognostic indicator of changes, forthcoming changes in ejection fraction. And so changes in strain actually predate changes in ejection fraction by 3 to 6 months. As we see here on this particular patient, her echo that was done then 3 months later at the 6-month surveillance does show that her ejection fraction has declined. And this was something that was perhaps predicted at her 3-month echo with changes in strain. Our third case is that of a 64-year-old female, and all these cases are highlighting different aspects of strain imaging and how it can be useful for different reasons in the oncology population. 64-year-old female. She has a history of lung cancer. She has non-obstructive coronary disease, so you know she has some coronary artery disease, and you know that she has an non-ischemic cardiomyopathy with an ejection fraction of 40%, and she presents to you for an evaluation of dyspnea. There are many reasons for this patient to be dyspneic, from her cancer, from her lung cancer, to potentially from her coronary disease, to potentially from her cardiomyopathy or heart failure. So these all need to be sorted out. This patient also has, looks like a small pericardial effusion as well. So on her echo, we see here a mildly reduced ejection fraction, and if you just quickly are reading a lot of echoes that day, may not notice that there is a regional wall motion abnormality. However, when doing the strain, it really highlights the regional wall motion abnormality in this patient in the basal inferolateral segment. The strain is significantly reduced compared to the anteroseptum and the rest of the apicolateral segment. And that is seen here also in the basal to mid anterolateral segments of this 4-chamber view. So this patient has regional wall motion abnormality in the lateral segment of the heart, and this is shown in the bull's eye as well. And so this is another area where strain is helpful for us to assess for wall motion abnormalities, assess also in patients perhaps with chest discomfort to see if there is a regional change in strain that correlates to coronary distribution. So perhaps this last patient in case 3 had dyspnea due to new wall motion abnormality. Case 4 is that of a 51-year-old female who had childhood Hodgkin's. She was treated over 20 years ago, and she received a treatment with an anthracycline regimen, again, type 1 agent, and mantle radiation, which is a large field radiation extending from the neck, the entire thorax. And she presents to you actually with severe symptomatic mitral regurgitation. As you can see on the non-Doppler image, the changes in her mitral valve are consistent with changes secondary to radiation. The anterior leaflet and the anterior commissure is calcified, heavily calcified, and this is something that we see in patients post-radiation treatment is changes to the anterior mitral leaflet and the anterior commissure of the mitral valve. The mitral valve is very thickened. There's restricted motion of both leaflets, and the patient has significant MR. But what was very interesting is actually when we did strain on this patient, we found that the strain on this patient was abnormal in the anteroseptum, the septum, and the anterior portion of the heart. And so that this change in strain in this patient may actually reflect the changes, long-term changes of radiation treatment that she had received because of the anterior anteroseptal distribution, the changes in strain. Case 5 is that of a 27-year-old woman. She comes to you, she has left-sided breast cancer. She's had bilateral mastectomies. She's also had dose-dense anthracycline treatment and 4 cycles, which followed by 4 cycles of Taxol radiation. She's receiving dual HER2 agents, Perjeta and Herceptin. And we're following her every 3 months. She is getting echo surveillance. Her echo as of September showed a normal EF and normal global longitudinal strain value. The patient comes to you, she's had an echo right before clinic, and is noted on her echo that her global longitudinal strain has actually decreased from -23 to -16%. However, ejection fraction has not changed. On questioning the patient, you could attribute this to her her chemotherapy. However, on questioning the patient, she was supposed to be taking Coreg and Ramipril, but however had run out of her ACE inhibitor and didn't refill it. And so the change in strain, you can hypothesize, may reflect actually her noncompliance to her heart failure therapy. So this is another very interesting thing to look at. But in summary, cardio-oncology, I hope I have shown that it's a burgeoning field. It incorporates advancements in echo technology alongside patient management, making patient decisions. Global longitudinal strain is a strong prognostic parameter in certain oncologic conditions and types of anti-cancer agents, that there is standardization and vendor-neutral platforms that will continue to lead to reduced variability in strain imaging. And some of the cases have highlighted that there are many uses for strain in cardio-oncology that are yet to be explored. Thank you very much.
Thank you, Dr. Akhter. To everyone in the audience, it looks like there was a bit of a miscommunication. We had some of our attendees show up about an hour ago, and some are just checking on now. We have recorded this webinar, so what I'm going to do is I'm going to send the recording out of the webinar to everyone in attendance, and it's an hour in length. So I'm going to send that now. Just a couple questions for you, Dr. Akhter, before we leave today. A few questions came up during the session. As far as how you've gotten the oncologists on board, you offered some tips. But are there education programs that your team is providing the oncologists and the patients to better understand strain? And for example, are you embedding those bullseyes into your report to better communicate what's going on with the patient?
It's really been an education on a one-to-one basis with essentially discussion with oncologists. And it will come up if there's a question about strain on the report. Right now we are not reporting the bullseye, but I think that's a good idea. Sometimes I'm not sure if too much information is, that would provide too much information, because oncologists really are only looking for one number on their echo reports, and that's the ejection fraction. But I think that their understanding for strain and the need for strain is growing, and they're asking for the strain number and the strain evaluation more and more. But it has been really more of on a one-on-one interaction basis with an oncologist when it comes up in their patient, or if it comes up on the echo report and they don't understand.
Okay, great. And then the other question is, when you're serially comparing these patients, are you using, even with a vendor independent software, do you still feel like it's important you follow that patient with the same scanner brand?
Yeah.
Regardless if you're,
the scanner brand is important, and sometimes even the sonographer which sonographer scans the patient, I find is important, and that is something that's also difficult to control in a large lab where, you know, the sonographers are changing positions in the lab. So sonographer training is so important when developing a cardio-oncology program, and to make sure that everyone understands how to do things correctly, to have a sort of an internal check to make sure things are being done correctly, to understand what these numbers are for. We have, at our lab, we have multiple different types of machines, you know, from different vendors. So we're not exclusive to one vendor in terms of doing our strain studies. So the machines, you know, will also continue to improve in quality, and I think that that may become less important, but I think that it's machine dependent and as well as sonographer dependent, both, in terms of how your strain comes out.
So with that said, is, you know, in cardio-oncology and other areas that you're applying strain, are there, is there a training program that is instituted with the sonographers? Is there a partnership with the physicians to get them, you know, to a set bar?
And we first started with a lecture series to explain strain, what its uses are, and then give examples of good and bad strain. It's really, and then we really just try it out. So, you know, we have independent sonographers who then would start off using it, start feel comfortable with it, but there was a backup availability as well as sort of super sonographers that become good at strain to be able to troubleshoot when it cannot be obtained. We also have installed a sort of an internal check in which sonographers can provide strain studies so that we can review that with them, what was done right, what was done wrong, to make sure that everyone is, you know, doing things the right way.
Great. Well, thank you. I think
but
that
it does take.
Go ahead.
It takes effort, and it takes mentorship, and it does take, you know, and it will take time. It's not something that will, you know, you'll see that you're able to just start doing within a month. It'll take a few months to feel really comfortable with it, and and even yet there will still be some people who will understand better than others. So,
great. Well, we appreciate your time today, and it's a very insightful presentation. And again, to the audience, we had, you know, a variety of you show up an hour before and then some now. So what we're going to do is send a recording of this presentation out to everyone later today. So thank you again, and have a great day.
Thank you.
Bye-bye.
Bye.